Okay. Good morning, everybody. Good to see you. So let me first thank you all for being here. We have some progress to report to you around our fire and EMS service, and I'm very happy to be joined by our fire chief, Chief Dean. Give Chief Dean a big round of applause. Our medical director for the fire department, Dr. Holman, Chief Baker, Chief Faust, Chief Mills, Chief Douglas, Chief Pearson, and our firefighters at this wonderful firehouse. So give them all a round of applause. We are here to highlight the incredible progress that FEMS is making and has made over the last 2 years. And I also want to talk a little bit about new legislation that I will present that will protect DC residents. So as mayor, I've had the privilege of meeting incredible people from every background and every neighborhood across the District of Columbia. And one promise we made is to make sure that we attracted great leadership for the fire and the emergency medical service here in the district, but also to make sure that all of the firefighters and medical professionals have the tools, training, and resources that they need to get the job done. So we chose to be here today at Engine 30 because it is one of the busiest in the entire city. The men and women who work here, they run into harm's way. They respond to emergencies. They meet our residents sometimes in the most difficult positions that they experience in their lives, and they provide professional services. And they respond to more than 500 DC residents who call 911 for help each and every day. And so that is why my administration has been so focused on making sure that Chief Dean and the wonderful men and women of fire and EMS have the resources that they need. So in the next few weeks, I will introduce a piece of legislation, and we call it the Affordable Emergency Transportation and Pre-Hospital Medical Services Amendment Act of 2017. This legislation will help close gaps in insurance coverage and ensure that more district residents have access to emergency medical care. It requires insurance companies to cover 100% of the costs associated with emergency ambulance and pre-hospital services. This bill is just a part of our larger effort to connect more residents to affordable and reliable services that they expect and that they deserve. And it routinely, when I first took office, let me just switch gears a little bit. The city was struggling to keep up with EMS call volume, and we routinely ran out of transport units, which is the most critical part of our critical patient care. These were not good days for fire and EMS, but we worked closely with our labor unions and with the council to invest $12 million in fire and EMS. This is the largest such investment in EMS in the city's recent history. And now the department is stronger and more resilient than it has been in many years. Today, we have more transport units. We've enhanced training opportunities for our fire and EMS teams. Our first response and transport unit response times are better and faster, and we vastly improved the condition of our fleet. We have more ambulances, more fire engines, and more ladder trucks. Since in the last 2 years, we have refurbished 16 ambulances and put them back on the street. These vehicles, coupled with our basic life support units, mean that we now have 23 ambulances in reserve. Additionally, we have been aggressive about adding more talent to the EMS family. And just in the last 2 years, we hired 45 more firefighter paramedics, and we're planning to nearly double that number with 2 more classes for paramedics later this year. We've also hired 48 firefighter EMTs and 36 cadets, the vast majority of whom are DC residents. Unfortunately, our outstanding fire and EMS teams can't be everywhere all at once. And we know that most incidents related to cardiac arrest become fatal if someone isn't immediately there and available to perform CPR. That's why we launched our Hands on Hearts CPR initiative and offered more classes on the basics of hands-on CPR to more Washingtonians than you can even imagine. I am proud that our efforts are making a difference. The overall bystander CPR participation rate for cardiac arrest in D.C. has increased by 20%. None of this progress would have been possible without the leadership of Chief Dean. So I just want to thank the Chief, his entire leadership team, and our entire Fire and EMS family for their hard work, their commitment to providing the best available services to the residents of Washington, D.C. So with that, I want to welcome Chief Dean to the podium to provide an additional progress report.
Good morning.
Good morning, Chief.
To Mayor Bowser and our guests, especially our director from the Office of Unified Command, Karima Holmes. On behalf of the men and women of the D.C. Fire and EMS Department, thank you, Mayor Bowser. The department's progress over the last 2 years would not have been possible without your leadership. We've made great strides, but we even have more work to do. There needs to be more advanced life support units available for our most critical patients. Our leadership team over the last few months has looked at this challenge, and we have concluded that we need more firefighter paramedics. With additional firefighter paramedics that Mayor Bowser mentioned, we will be converting 3 of our basic life support units into medic units. We plan to make this change on March 5th. Working collaboratively with Local 36, we're planning to pilot a different staffing model for these 3 units, where the station houses will be responsible for staffing both the medic unit and the paramedic engine company using their assigned members versus the way we did it before with detailed members. We're trying to pilot this to determine whether such a staffing model will yield efficiencies in staffing, managing supplies, medication monitoring, training, teamwork, and other areas. The change is also consistent with another pilot we did with Local 3721 to move their members to a 24-hour shift schedule last summer. This change became permanent for all Local 3721 members in January. We're excited about how the pilot project improved our work together as teams in their battalion and expect this change to continue to reap benefits throughout the department. We continue to look forward to make changes in the way we operate in order to better utilize our existing advanced life support resources. Our goal is our paramedics should be doing only paramedic work. Our ALS providers are highly skilled, but they're a limited resource, and we need to preserve their availability for our most critical patients. We have been monitoring this issue for several months and have seen a decrease in the percentage of time that our ALS providers are transporting basic life support patients, which is encouraging. Another area of interest, we've been making every effort to transfer our patient care times at the hospital. It starts with members utilizing AMR for non-critical patients, where possible, so they're not at the hospital. Also, we established a goal of 30 minutes for in and out of the hospital for each one of our ambulances. While there are some aspects of hospital transfer care time that is out of our control, there's also room for improvement. In all cases, we have the opportunity. We not only want to make our ambulances and medic units available, we're trying to increase the time that they're available in their local alarm district. If we're going to be able to do that efficiently, patient transfer must become important to each and every one of our members. We've seen a drop in our hospital times. It's a meager drop today, it's 3 minutes, but we believe with our members working closely with us that we'll continue to see that drop till we get to that 30-minute timeline. All these efforts, coupled with the addition of AMR, have translated into greater unit availability, which has resulted in improved response times, additional hours. We're able to provide our members with valuable and necessary training. Regarding response times, we've seen an improvement of 41 seconds in our first unit on scene. Our average ambulance response time has also improved from 8 minutes and 7 seconds to 6 minutes and 30 seconds. This has particularly benefited east of the river, who before AMR frequently had to wait for ambulance to come from the hospital to Northwest, which for critical patients resulted in response times that were too long. We responded to over 200,000 emergencies last year, and I can tell you to the person, the residents and visitors are the reason these men and women put the uniform on every day to work. We have improved the training, resources, and supports to all of our employees to ensure that we are providing the best service and care possible, while also making sure that our members make it home safely to their families and loved ones after every shift. A big part of this effort is Dr. Robert Holman, the department's interim medical director. He has taken on several projects and initiatives that we believe will continue to make us better tomorrow than we are today, like the Integrated Healthcare Collaborative. Dr. Holman?
Thank you. You're welcome, Dr. Thank you. Good morning. I'm Dr. Robert Holman, and before turning to the release of our Integrated Healthcare Collaborative report, I would like to talk a little bit about our new EMS training initiatives. First, starting this spring, we will begin the Enhanced Pediatric Emergency Training in partnership with Children's National Medical Center that will include 8-hour clinical training for paramedics that focus on acute emergency asthma treatment and pediatric triage. In addition, our new paramedic grand rounds will include quarterly 4-hour symposia to be conducted by local medical schools and medical centers. Our first session starts March 28th. For our BLS providers, our focus will be on company-based and case-based training with the rollout of 2-hour modules that will be presented by company officers at the station level. This will launch in the next 2 weeks. And finally, we will continue our modular approach to the delivery of required continuing medical education, CME, as part of the National Registry and the D.C. Department of Health recertification process. This is a revised approach that we started in early 2016. Instead of the traditional single continuous 36-hour block that occurred biannually of CME, we have created 4-hour blocks or modules of rotating topical content that is structured to meet our recertification requirements while providing us the flexibility to add any operational or quality improvement-driven content. Learning in 4-hour blocks throughout a 2-year period is greatly preferred to a continuous single 36-hour block. I would like to thank our partners at the Department of Health for supporting this evolution, because as our state EMS regulator, they've had to approve these new approach, and they've been very supportive in getting us there. Now, switching gears to the Integrated Healthcare Collaborative. As the interim medical director for DC Fire and EMS, and under the leadership of Mayor Bowser and Chief Dean, I'm spearheading efforts to discover and develop new paths to more appropriate avenues of care for the close to 200 people, our low acuity callers, who call 911 each day for non-emergent medical reasons. These low acuity calls are neither limb nor life-threatening, and these patients can better be served in an outpatient care setting. Currently, Washington, D.C. has the 8th highest call volume in the entire country, yet we rank as the 24th largest city. And 48% of our 911 calls are assessed to be low acuity by our call takers. We've known for a while that something has needed to be done about the large volume of our low acuity callers beyond just increasing the number of our emergency resources for these non-emergent calls. So last April, the Integrated Healthcare Collaborative, or the IHC, was launched. Today, we are releasing the IHC's final report, which outlines its findings and recommendations, and which, if implemented, will result in delivering better medicine for our many low acuity 911 callers. This effort could never have reached this stage had it not been for the full support of Mayor Bowser and the involvement of many members of her cabinet. Other stakeholders, both within and outside City Hall, have played vital roles by developing feasible solutions that we hope will not only ease the department's overburdened EMS response network, but will also provide better outcomes for thousands of district residents and patients. So thank you to the city's 3 Medicaid managed care organizations, AmeriHealth, Caritas, Trusted, and MedStar Family Choice. Also providing valuable information, insight, and direction in this endeavor are the following: the DC Primary Care Association, the DC Hospital Association, the Department of Health, the Department of Healthcare Finance, the Office of Unified Communications, the Office of Aging, the Department of Behavioral Health, the Department of Vehicles for Hire, Local 36, Local 3721, and even Georgetown University. You now have a copy of the Integrated Healthcare Collaborative's final report, but let me just go over a few highlights. We are recommending the establishment of a nurse triage line that would become part of the Office of Unified Communications 911 system. OUC call takers on the receiving end of the initial 911 call would be able to screen these calls and connect these lower acuity callers to a triage nurse for further assessment. With the guidance of well-established protocols and using his or her clinical training, this nurse is able to further assess and direct a caller towards non-emergency department resources, including self-care advice or non-emergency transport to primary care clinics or an urgent care center. And in rare cases, the nurse may flip back the call to an emergency transport to an emergency department. If medical care is advised, then this nurse triage will schedule the appointment and arrange a means of transportation for same-day care. One of the IHC's subcommittees identified 16 clinics in the district that accepted all insurances, including those without insurance, had extended evening and weekend hours, and provided on-site behavioral health, case management, and social services. The real goal behind the IHC is to help build a long-term and beneficial medical relationship between these patients and the primary care providers. The IHC really serves 3 purposes. It seeks to reserve the emergency transport for those with potentially life-threatening illnesses. It serves to relieve the district's emergency departments from some of their overcrowding. And most importantly, it serves to direct these needy and often quite vulnerable patients to same-day comprehensive care. We are really excited to announce the progress so far. Thank you very much.
Thank you. Well done. Well done, Dr. Holman. So we're happy to take a few questions. I'm going to start with the press first, okay?
I'll be the press.
No, I promise I'll get to you. If there are any press questions, speak now, speak now.
Yeah, we have some questions.
Okay.
So on the insurance component, can you explain, when you say you're going to collect more money or require insurance companies to pay more for 911 service, what does that mean? Does that mean, or what does that mean?
We're actually going to require them to pay for the cost of an ambulance ride. Currently, there may be a balance left over from what what is billed for the ambulance ride and what the insurance pays. And right now, that balance is billed to a DC resident. So what we're saying is, insurance companies, you must pay for the cost of the ride. Anything to add? Okay.
Does it change? Is the amount that we are able to charge for ride governed by like a Medicaid agency or?
So the Medicaid is not changed. This is for the private insurance companies so that they're paying the full cost versus us billing the patient personally.
And so currently an insurance company, Joe Smith got transported by ambulance, got a bill, his insurance company, for whatever reason, only paid 75% of that transport. The rest would fall to the patient. You're going to require the insurance companies to pick up 100% of that cost.
Correct.
So are you concerned of what that might do to healthcare premiums for users? How do you protect the residents, the insurance people who are buying insurance from seeing their premiums go up because of this change?
So actually, this was actually a recommendation that came from the Healthcare Insurance Committee that we're moving forward.
Right. So what makes you think that they won't raise insurance rates?
So I don't have the answer for you on that one, Mark.
But our insurance commissioner reviews any rate increases in the District of Columbia to make sure they're fair and reasonable. And not having seen the specific studies, but they will be looking to make sure that any rate increases are associated with real costs.
What is currently the recovery rate the DC gets on these bills that they send out? And are you going to do anything to go after those in a more aggressive manner? Because my understanding right now, the district doesn't really go after those people. If an individual gets a bill and they don't pay it, the district doesn't really go after it.
Well, that's why we want to focus on the insurance providers paying for the ambulance ride. We're a city where we have almost 100% insurance coverage. So there's really no reason why a DC resident should be getting a bill for an ambulance ride.
Do you have an estimate on an average cost
I do not know that number exactly.
Do you know how much additional revenue you expect this will generate for the city if you simply?
It is going through the Office of Contracting and Purchasing right now. They've not come up with a number.
So one thing I think we are going to recommend that the additional funds will be isolated for and reinvested in EMS reform. So some of the things that we've been talking about, those monies are going to be collected and invested in additional EMS work.
Currently, the money covers ambulance billing.
I know. Okay, I'm sorry. All right, I have to go to. Well, not have to. I'm delighted to go to Sam Ford. Okay, I didn't see you, Sam. Okay, you're right. You're right. Sorry.
How long has it been? Has it been a year since you started this AMS program? About a year? Or?
The third-party program started March 28th.
Okay, so about a year. So as we drive around D.C., we see these little ambulances driving around with lights and sirens. Has it made a difference, and can you quantify that in some ways?
Yes, we can. So we're seeing an improvement in unit availability. We're seeing an improvement in our response times. We are seeing an improvement up to 33% increase in our training hours. And we're seeing an improvement in our preventative maintenance, the areas that we talked about as we were bringing this on board.
So maybe it's just me, but I don't recall hearing a lot of these horror stories in the last year or so. Is that because of these additional units that are on the street?
Can you repeat that?
Again, I think that AMR, along with the training that we've done with our personnel, the availability of units, and keeping units in their first response district has really had an impact on our ability to provide a service to the community.
Now, you talked about it. Response times have improved. You said they've gone from 8.8 minutes down to 6. Is that correct?
That was for our transport units. Our first units on scene are getting there about 41 seconds sooner, and that's the fire engines and ladder trucks that are right in the station in the neighborhoods.
And then finally, for me, what do I believe, this book or what you all said? I mean, you, for example, said that there were 200,000 emergencies last year. This book says 170,000. The doctor said there was 48. There was a 48% instances where basically the people really didn't need emergency care. This book says 72.
So again, I think what you're looking at, Sam, is that this was the Integrated Healthcare Collaborative that was looking strictly at medical alarms. When I talk about the over 200, I'm also including the fire alarms and all the other responses we go on at the same time.
Oh, so this is fire and EMS, everything.
That's
okay.
that's EMS that you have. What I spoke about was fire and EMS.
And the doctor, this says 72% of the cases, they're not really emergencies. That's what it says in here, but you said 48.
Thank you. So what I said is that 48% of our 911 callers are assessed to be low acuity callers at the call taker level. When our members who have much more skill and experience get out to the field and they assess the patient in the field, about 72% of all calls are then judged or assessed to be low acuity callers.
Let me help.
Yep.
So let me help a little bit with that. So what we're really saying is this, is that we believe that we've been over-sending. So if 48% are BLS calls, that means 52% are ALS. And the reality is really only 20% of our calls should be ALS. So that 72% gets us closer to that number. So that's what we're really saying is by using the nurse triage, that will allow us to ensure that we are sending the appropriate resource to the appropriate type call.
Let me just add, and I asked that Karima Holmes join us today because she's also the director. She is the director of our Office of Unified Communications. Director Holmes and Chief Dean and his staff have worked also very closely together to make sure our call takers and the protocols that they use are also helping us lower our response times. And I'm very grateful for the work that they have done. We also noticed 2 years ago, and I think in the case of OUC, there hadn't been any new investment in call takers in about 8 years. And over the last 2 years, we've been able to add 30 additional call takers. And I'm also grateful to Director Holmes because she used our LEAP program, which is focused on hiring DC residents to fill those positions. So we've been able to add more call takers, provide more training to those call takers, and more training to our EMS providers because of the system that Chief Dean has put in place. We'll take a few more questions. Yes, Ms. Rucker.
Well, first of all, I want to thank the men and women of the fire department and communications for serving us so well. I know the city swells through a large number of people during the middle of the day, and I want to thank you all for your hard work. I live here in Greenwood. I have 3 questions. One, I want to thank you for adding the nurse triage line. One recommendation that I would have...
It's still in the recommendation phase. I just want to say we're discussing it today. Yep.
I'm making another recommendation.
Okay.
We have nurse paramedics or nurse evaluators. I don't know if you all still have those, but that might be another level of support that you all have. The second thing I'd like to know, I see the faces behind you, and I'm wondering how many are district residents and when we're going to start using the LEAP program to service EMS and fire, and also integrating it with more women. I know you all have the cadet program. I was with Dr. Victoria County as an intern with the fire department when we looked at that. So I'd like to see that leverage to a better level.
Okay.
And then the third question that I have for education, I really want to see the education piece taken to another level. Not saying that the company officers can't do it, but I know in the past when I was with the fire department from 1990 to 1994, if there was a fire or an EMS call, firefighters were going to jump on the fire truck because they want to put that fire out because that's their training and that's what I need them to be able to do. And I can still tell the difference between a medical local and an EMS call by the way the trucks roll out.
So let me get to your question. I want to ask the chief to specifically talk about our hiring initiative at Fire and EMS, the cadet program, and how we've grown our ranks. You bet.
How you doing, Ms. Rucker? Good. So we have we gave a test in June of 15. We've been hiring off that list, and 80% of the people that we've hired, or actually 90% of the people we've hired, have been DC residents. We continue to bring both men and women in through our cadet program, and we are. Let me see if I remember the next question.
About the cadet.
We regarding nurse paramedics riding on the EMS unit?
We're doing a different way, and we are looking to use firefighter paramedics to be able to carry that along. We believe that the training, as Dr. Holman's talked about, that we're doing at the universities, as well as our monthly training, will give us that same level with the doctor and the assistant medical director following and ensuring that they're getting the coverage that they're getting. And the last piece you asked about was the fact that they would rather fight a fire than okay, so let me be clear that we have come on and we've been very clear, and our members have embraced the fact that we have a multitude of jobs, and each job is important. And so, regardless of whether we're getting on that rig and we're going to save somebody, medical or fire, we take them both very seriously, and that will be continuing. And as the years go on, I would love your feedback to see how well we're doing.
You all are doing a great job because you save the lives every day. The other thing I'd like to add is one of the 15 components of EMS is education. People used to call the 911 center and ask for a tabulator. So one of the things that we need to do for the public is to fulfill that commitment to EMS and educate the public on what is appropriate to call EMS for. Because if you have a 72% rate that it's not that urgent, that's a problem. And there needs to be an education done on the level of the citizen.
We agree with you, and if you look in that pamphlet right there that we gave you on IHC, you will see that public education is one of the components that the IHC came up with to make sure we educate the public on how to and when to use 911. So I agree with you.
Yes, last question, sir.
Do you have any concerns that along the same lines that by shifting the cost of this to the insurance companies, that you're going to have any trouble decreasing the number of people that use the 911 service for transport unnecessarily?
No, we think that there are a lot of parts of our system that encourage people to call for an ambulance when they don't really need one. And I have to tell you that I would venture to guess that cost portion is not a big driver. All right, thank you, everybody.